Right, so I think we'll make a start. So it's my great pleasure to invite you all to this webinar organized by the Las Casas Institute at Blackfriars College. My name is Joseph. I'm a health economist based at Nuffield Department of Primary Care Health Sciences. A bit about the host institution for those who are new to webinar like this. The Las Casas Institute for Social Justice is a vibrant center for research, dialogue, and policymaking on the common good of humanity and nature in the world today, which welcomes discussion with people of goodwill. All people of goodwill. The Institute's work is rooted in Catholic social teaching and the example of Bartolomé Las Casas, who argued for the humanity and rights of all peoples in the Americas in the 16th century, and is one of the early pioneers of universal human rights. It's also my great pleasure to invite tonight's speaker, Professor Stephen Duckett. Stephen is an emeritus professor of health policy at La Trobe University, a member of the Religion and Social Policy Network of the University of Divinity Australia. He's a fellow of the Academy of Social Sciences Australia and also fellow of the Australian Academy of Health and Medical Sciences. He holds 2 doctorates, one in health economics, the other in theology. Tonight's webinar is based on his second doctoral thesis, which was published by Cambridge University Press in 2023 under the title Healthcare Funding and Christian Ethics. If I may contextualize a little, much ink has been spilled on the theology of clinical practice, on the hard ethical issues that arise in doctor-patient encounters, and on the virtuous clinical practitioner. Far less has been written on the theology of healthcare system as a whole, even though it is very much the system that shapes incentives and resources of clinical practice and public health more broadly. Stephen is therefore very much a pioneer in bringing this topic to the forefront of theological discussion. His long years of academic research and government policymaking in Australia lent incredible authority to his diagnosis and proposals for this field. So without further ado, I'll hand over the floor to Stephen, and he'll give his presentation for about 40 minutes. And please put your comments and questions in the chat during that period, and we'll open up the discussion and Q&A afterwards. So, Stephen, the floor is yours.
Thank you very much, Joseph, and thank you for those kind words. I'd like to start, as we do in Australia, by acknowledging that where I'm sitting here in Melbourne is on the unceded lands of the Wurundjeri people of the Eastern Kulin Nations, and pay my respects to elders past and present. As Joseph said, this arose from my theology doctorate, and it is at this intersection. If you imagine 3 corners of a triangle, one about theology or ethics, one about healthcare, and one about economics. There's lots written about ethics and healthcare. There's a huge field of bioethics. There's lots written about healthcare and economics. There's a huge field of health economics. And there's lots written about theology and economics. But there's almost nothing written about all 3, which is what I was interested in exploring, partly because of my background as a health economist and partly because of my interest as an amateur historian, amateur theologian. Now, I'm going to try and share my screen, which hopefully will work. And I hope you are now seeing my screen. Is that what you're seeing? Good.
Yep.
Thank you. To give you a little bit of a direction about where we're going, I'm trying now to, whoops, sorry, get the screen to move on. Sorry, this is, yeah, maybe I have to do that. So where I'm starting from is that the assumption that you can deduce wider ethical principles from Bible stories. Robin Gill, I think, pioneered this sort of analysis where he looked at all of the healing stories in the synoptic gospels and deduced a set of ethical principles. His argument was that the Beecham and Childress sort of bioethical principles don't come from anywhere. And he was looking for a set of principles which are grounded, in his case, in the synoptic stories. Robin was my supervisor, and so it's not a surprise that I took the same approach and said, can we deduce some ethical principles or Christian ethical principles from the Bible? And I suggested that you could from the Samaritan story. And I don't think I'm imposing too much of my own views on the Samaritan story, because the same sorts of principles occur in other parts of the Newer Testament. And so I'll show you how I got these, identified 3 principles, and what this talk is about is particularly about the implications. If we go into the screen sharing, I can't move it along just with my cursors for some reason. Sorry, there you go. So the Samaritan story, as you know, is very, very well known. Interestingly, some have argued that it is a universal story. That is, it's not only a story that appeals to Christians. And the story is set when a lawyer stood up to test Jesus and said, "What must I do to inherit eternal life?" And the setting is the question of, who is my neighbour? And so then we have the story. This illustration on the right-hand side is actually in a church in London, which I have been to. So we have the man going down the side of the road, blah, blah, blah. And we come to the Samaritan sees the person on the side of the road, has no idea who they are, because they have been stripped, and so they can't identify by the clothing that the person was wearing. And the critical thing here is the Samaritan was moved by compassion, and I'm arguing that that's one of the principles that we can see in this story. Then the Samaritan put the person on the side of the road on his own animal, took him to the inn, took out 2 denarii, which was a lot of money, and gave him to the innkeeper and said, "Take care of him." Now, I'm arguing that this talks about stewardship, that the Samaritan had an expectation that the innkeeper would look after that money wisely and spend it only on what was necessary. And then we come to the denouement, that Jesus says, the question here is, who showed him mercy? And, which of these do you think was the neighbour, the man who fell into the hands of the robbers? And we get the answer from the lawyer, the one who showed him mercy. And so here we have the next principle, which is about treating everybody as a neighbour. That is a principle of social justice. So we end up, I would argue, with 3 criteria that we can see in this story, and so we can ground our principles of social justice in this concept of biblical ethics. And importantly, I argue that no one of these is preeminent. I argue that each of those has to be held in tension, that they are not in conflict. That is, some people will say, oh, you can't have equity and efficiency, or whatever, or you can't have efficiency and compassion, which has been argued to me. So that the complexity of the issue is holding all 3 of these in tension simultaneously. So if we go back to our Samaritan story, the the Samaritan was moved by compassion. So compassion was a motivator for doing things. We also have social justice, everybody is your neighbour, and that's sort of a basis for the distribution of benefits. So it's a different dimension in a sense. And finally, the context is stewardship. That is, healthcare has to be provided in a context where we have to be concerned about the funding. Now, interestingly, the Samaritan story is about an individual doing individual things. That is, the Samaritan caring for, both now and while he's away and when he comes back, caring for the person on the side of the road, the unknown person of unknown origin. And so it could be interpreted as quite an individualistic endeavour. But Martin Luther King, in a sermon, drew attention to the issue that healthcare and healthcare economics, well, not healthcare economics, but in his view, we are called to play the Good Samaritan on life's roadside, but that will be only an initial act. One day we must come to see that the whole Jericho Road must be transformed so that men and women will not be constantly beaten and robbed as they make their journey on life's highway. True compassion is more than flinging a coin to a beggar. It comes to see that an edifice which produces beggars needs restructuring. And so here, Martin Luther King is arguing that there is what might loosely be called in healthcare a preventive element, that stewardship, in a sense, requires us to think beyond the individual patch-up, beyond the individual response to an individual need today, but rather to looking back upstream, as the public health people say, to what creates that individual need and what should be done to address it. So the stewardship forces us to think about prevention at the same time. There's another good little book, I think, from Laura Stoger's, where she highlights 4 different approaches to homelessness from a Christian perspective, which start with what she calls an ameliorative response, that is, responding to the individual need. Now, she doesn't say that's wrong, and it's of course not, but she also says that it is insufficient. That is, our response to homelessness should look upstream at how homelessness is created, and she has 4 different levels of how Christian churches might respond to homelessness, and the final level is about changing the conditions in society which lead to it, which is sort of what Martin Luther King is also saying. So turning to the issues of economics or stewardship, I argue that stewardship has 2 main components in a health economic sense. One is being prudent in the use of resources, eschewing greed and overconsumption. The phrasing is taken from a number of sources. And the second component is simultaneously being concerned about social justice and those outside the immediate household. Economy comes from a word which in Greek loosely means management of household well-being or assets or resources. Anyway, so I'm arguing that this tension between stewardship and social justice is in part addressed by bringing social justice into the stewardship issue, as I'll suggest in a minute. So what on earth do we mean by being prudent in the use of resources, eschewing greed and overconsumption? What are the policy consequences or concepts that we are talking about here? Well, the first one is this issue of economic evaluation. And this is a somewhat contentious one in some parts of the world, including the United States. And I saw that there was someone on the line from the US. And the whole basis of economic evaluation is this issue of scarcity. And again, this is even though it is a fundamental of economics, one might argue that we live in a world of abundance, for example, but in a sense, in most of the Anglophone world, but in most countries which have essentially a publicly funded healthcare system, we have to set priorities about our spending on healthcare. And this means we have to make judgments about what should be prioritised over what else. Now, sometimes, in my view, erroneously, we talk about valuing human life, and we all would have a bit of a frisson of, can we do that? Is there not an infinite value on human life? And how on earth do you do economic evaluation? And I think that part of the problem here is caused by a bit of sloppy thinking. So in my view, economic evaluation does not require us to put a value on human life, but rather it requires us to put a value on another 365 days of leading a happy and contented life relative to some other sort of life. And in effect, what we're asked to do in economic evaluation is to make some sort of assessment that on average, and it's not each individual, people needing this treatment will have a greater or lesser likelihood of an extra period of life or extra quality of life if an intervention is approved or not approved for funding, and that if approved, the expected benefit will be in the typical range. So first of all, what is obvious from that sort of definition or that sort of description is that we are not talking about applying things to individuals. Rather, the process is about statistical lives. Obviously, the statistical lives are converted into individual treatments, but it is not saying you're not worth anything or you are worth a lot or whatever. And I'll come to one of the issues associated with it in a minute. Helpfully, Eric Nord, a health economist, has identified this question of language, and he's talked about three different sort of concepts: the worth of the person or the value of a person's life, the impact on a person's well-being of a condition, and the desirability of some conditions of life, and conversely, the undesirability of other conditions. And if you think of that last dot point as essentially what quality-adjusted life years, a key metric in the application of economic evaluation to the health sector. If you think about quality-adjusted life years, the metric is, in a sense, much more about talking about the desirability of some conditions of life and conversely the undesirability of other conditions than it is talking about the worth of a person or the value of a person's life. It is a metric about the third dot point, not the first dot point, contrary to what many people might argue. And I think, as I said, as a consequence of this somewhat sloppy thinking that we see. Obviously, then, I've mentioned already this issue of statistical lives, and the principles of economic evaluation and the application of economic evaluation come up against hard choices of the rule of rescue, as I describe it. That is, we often see stories in the media about individual cases where if government approved this drug being listed or this treatment being approved, then they will be saved, and if not, they will die or live in great difficulty. Time. Now, just as a personal aside, this year, unfortunately, my daughter has been receiving treatment for lymphoma. She's now fully in remission, which is a good thing. But, you know, I would sit there next to her bed and watch the drug in the pack being infused into her body. And it, I think, was $10,000 a minute, which was going into her blood and into her body. Now, obviously, I'm not paying that. The taxpayers of Australia are paying that. But she's 30 years old, and it meant the difference between her dying and her living for the foreseeable future. So you have these cases of individuals in front of you where they're presented in the media as a case study, and we should spend zillions of dollars on these people. So the way we've got to recognise that, inverted commas, not everybody thinks like an economist, close inverted commas, and that society has an attitude of compassion in these cases, which ethicists call the rule of rescue. That is, there is a tendency to override the inverted commas economically rational decision. And the way this is operationalized in the health economic evaluation approach is through an end-of-life premium, recognizing that to some extent there may be that society may value investments which on the face of it might not seem economically rational. And so a number of economists really criticize the rule of rescue, but in my view, it is consistent with an emphasis on compassion. And so it's holding the compassion and the stewardship issues in tension. Now, the prudent use of resources and so on is all about, there's a whole set of principles about how you actually make allocative decisions, the need for transparency and so on, which I think can be ported into a Christian ethic of stewardship. Now, you might, on the face of us, think that economic stewardship and social justice are actually alternatives. That's not my view. But the second of all, one of the principles I identified of social justice, in my view, can be incorporated directly into the concept of stewardship by saying that at the same time as we have to worry about stewardship, we have to worry about social justice. And there are a number of aspects of this. The idea that resources are rationed, and if you spend something on someone or some group, you can't spend it on some other person or some other group. And so you look to see what might be a maximum good for the maximum number sort of approach. But I think it's somewhat different than that, because the approach to economic evaluation has evolved over time. So if you're making a decision about a new drug, for example, you'll have a threshold that if the benefits are greater than this, or the benefit, the incremental cost effectiveness ratio, that the ratio of benefits to costs above or below a certain threshold, the answer is yes or no, and there's an indeterminate ground in the middle. And there are a number of factors which impact on decisions on that indeterminate ground in the middle. Now, what's interesting is over the last couple of years, maybe 10, there's been a lot of work on the issue of distributional cost effectiveness analysis. That is, incorporating into the very cost effectiveness analysis a quantification of the equity impacts and trade-offs. So you now no longer have a one-dimensional cost effectiveness analysis, but you have a two-dimensional that incorporates equity principles in the very decision-making process and cost effectiveness frame. That is, if the benefits are skewed to only affect wealthy people, or the benefits are skewed to only affect poor people, this is incorporated into that cost effectiveness decision. And in my view, contemporary economic evaluation based on a Christian ethical principle ought to be based on distributional cost effectiveness analysis. So that is focusing a lot on the stewardship question and what the consequences are. We also need to think about compassion, because the compassion is a word that we rarely see in public discourse. We often see efficiency or equity or social justice in the public discourse, but we don't necessarily often see compassion. And obviously, compassionate leadership, I think, or Michael West thinks, has a number of components. I agree with this, that if the leadership is not effective, that is, it is not clear, shared vision, and so on, it's essentially not leadership. But similarly, compassionate leadership is inclusive. So linking compassion here to social justice. But what's interesting here is that compassionate leadership involves both a collective approach, that is, not simple hierarchical, but it also involves a more forward-looking approach. And so it links this issue of compassion and stewardship to what economists might look at as dynamic efficiency. But we're beginning to see the different concept of leadership, and not just direction and hierarchy and so on. Now, linked to this issue of compassionate leadership is this question of what are the implications of that in our day-to-day life in an organisation. And you might think of, we have measures in the health sector about what might loosely be called patient-assessed values, most obviously represented in what are called patient-reported outcome measures, sometimes patient-reported experience measures. We also have, as a different dimension and measuring a different thing, clinical assessed value. Sorry, my typing's there, no good. But such as measures of clinical quality, and finally, measures of efficiency. So what I would argue is that in a organisation which holds these three principles in tension, you also have three measures that need to be held in tension or need to be incorporated in any so-called balanced scorecard. And here we begin to see that organisations which only are obsessed with efficiency, or indeed are assessed with both clinical quality and efficiency and forget the patient-assessed value, are not holding all three of those principles in tension. So finally, I'm going to come to what are the impacts of all of this on payment design. And I have two dimensions here I'm going to talk about. First is primary care, and the second is acute inpatient care. And if you think about it, primary care, general practice, family practice is all about managing acute presentations and managing care of people with chronic illness. Possibly today you ought to change the order of those two. But if you think about it, what are the three dimensions I'm talking about? Social justice no financial barriers to access is a key element of that. Stewardship, responsible use of resources, key element of that. Compassion is about access. I've described it here as access to high quality services. But so what are the implications for policy for if you were implementing a policy of based on these three principles of compassion, social justice, and stewardship? How would it play out in how you might design payment design for primary care? Well, I would argue it plays out in terms of no financial barriers, no out-of-pocket payments, but also ensuring that your primary care system not only provides primary medical care, but also goes beyond to provide some things that address social determinants, including through social prescribing. And what do you do about stewardship? Well, there's this issue of payment design for organisations. Do you have a capitation approach or a fee-for-service approach? I would argue that the evidence suggests that you should incorporate elements of both, that is, a so-called blended payment. But most importantly, you should actually be beginning to talk about pay for performance, not so that you crowd out intrinsic motivation, obviously, but also that we begin to emphasise trying to achieve outcomes and trying to reward outcomes. And there are many, many ways in which this might be implemented. And obviously, compassion is about ensuring good access to holistic primary care, and also coming back to pay for performance, this issue of quality. Turning to the issue of acute inpatient care, similarly goal about restoring people for function. Again, if we're emphasising social justice, we would not have out-of-pocket payments. If we're emphasising stewardship, I would argue you drive efficiency through activity-based funding, prospective payment, they call it in the United States. But it is not unlimited. That is, you need to be thinking about capping. And again, you have activity-based funding. So in terms of compassion, my first dot point there is there has to be time for compassion. You can't set your activity-based funding payment rates so low that staff don't have time to provide good quality care. That is, you squeeze out any ability for staff to respond to the human needs of the patients they're talking to. Again, we come to this issue of pay for performance. So there are questions, obviously, that need to be addressed by everybody in this world. What did the current metrics privilege? I've highlighted there this issue of making sure the base payments are right, this question of work intensification, potentially crowding out compassion. Again, there's a developing literature on that, and what might loosely be called radical compassion, that is coming back to the Martin Luther King story at the start of this talk about prevention and action rather than just responding to individual needs. Also, this question of talking about how does suffering work and how do we stand with the other person and show our compassion. The late Archbishop Tutu talked about the very definition of a human being is a person depends on others to be a person. That is, we cannot exist in a world and call ourselves a person unless we have interactions and relationships and dependency with other people. And as I've argued before, we need to recognise human dignity. That doesn't mean we're valuing life. And also, if we're health workers, we need to be thinking about self-compassion. The Samaritan story to end was not about doing things, but which is how the lawyer started the story. What must I do? And the answer was, it's not about doing, it's about being. You must be a neighbour, and which is a much harder task. So my argument here is the three, just recapping the three principles are there in the Samaritan story. I elucidate it at length in my thesis, which turned into the book, with that stained glass window in that church in Kensington High Street. So thank you very much. I will stop sharing and to questions. There you go. Thank you.
Thanks, Stephen. Thank you for that. Does anyone want to come in at this point? Otherwise, I will come in. Anyone wants to come in at this point? Okay, so I'll come in, and obviously I'm coming from a health economist, so I'm always very sympathetic towards my own profession. So we're trying to solve common challenges and criticisms. So one criticism that we get is that, yes, we don't value human life, but the problem is that a quality gained by a life-saving technology, say appendectomy, is valued similarly to a kind of a health promotion intervention, say like cholesterol prevention, or other things. A quality gained there, appendectomy is the same quality gained through another intervention. And it led to that episode in Oregon where tooth capping was ranked higher than appendectomy for kind of public reimbursement. So I think that's called in literature a priorities problem. So don't you think like northern people, by saying we're not trying to value human life, we don't do those kind of things, is perhaps trying to dodge the issue a little bit? Because there are kind of major ethical problems when you're trying to compare across different disease areas and different severities, and different life-saving and non-life-saving technologies. And perhaps like a German model where they're not comparing across diseases is possibly an ethically cleaner way to go.
Good question, Joseph. In a budget-constrained world, in a Westminster type system, the cabinet makes priority choices every year about how much should be spent on education, how much should be spent on health, how much should be spent on transport. In a totally economically rational world, there'd be some sort of ability to measure the value of those investments in human well-being. Now, I would argue, and obviously I don't think any of us live in a country which has totally economically rational approaches to setting budgets, but I would argue that the closer you get to that, the more well-being would be maximised. But the more you try and make transport investments or education investments or health investments mensurable, the more difficult it is, the more strain you're putting on the assumptions. And then the same issue applies within health. The more you are ranking a preventive intervention versus a curative one, or even within curative ones, the cancer intervention versus an acute surgical intervention, for example, the more you are, I won't say doing violence to the quality methodology, but the more you are assuming that all of these things can be put on a single ranking scale with those properties. Now, that's the assumption of quality, and it's assumption of the incremental cost effectiveness ratio. But one is always safer in going to the most comparable, that is a randomized controlled trial looking at two interventions for the same condition, which one is better, which one is more cost effective. The more you go away from that, the more you're making assumptions about equality as equality as equality. Now, I'm happy to go broader. I would also argue that our decision-making about prevention should not only be about the same dimensions as our decision-making about curative. That is, in a sense, there's a rule of rescue type issue here that something, because often preventive interventions have a longer time frame and we end up into this issue of discounting, I think sometimes things that society thinks are appropriate to do on a moral basis are excluded because they're not seen as cost effectiveness with a particular discount rate on an economic basis. So I think the issues and the applications of stewardship principles do have to be different across even different components of the health sector. But I think we need constantly to be talking about the issue of stewardship, about the importance of making sure our decisions are, to some extent, economically rational.
I think Edward asked what the German system. Basically, Germans don't like comparing across diseases areas, whereas in England, in other countries, we combine whatever disease, we try to measure it in terms of kind of similar metric, so we can compare allocations across different diseases and different interventions. But Edward had another question. I'm troubled by the use of rationality, quote, rationality in healthcare economics. Is the stuff of medicine, health, illness, death, care, complement, cure really best described by the narrow utilitarian understanding of reason? Which I think we've been discussing already, so we can expand on that.
So I would argue the answer is yes and no. That is, you cannot simply make your decisions on that one dimension of economic rationality. You've got to take into account social justice and compassion. All three have to be held in tension. And if you emphasize one too much, as I think our society tends to, you end up with not morally rational decision making. So yes, I said it's a yes and a bit of a yes, a bit of a no. That is, you cannot dismiss the economic rationality of the stewardship question, but emphasising it too much leads to wrong decisions in my
view. And if I may come in again at that point, I'm wary that I don't want to make this whole thing into a technical discussion between health economists, but let's take the distributional cost-effective analysis, which tries to take into account social justice and efficiency, but it's trying to do so in a way that they're quantifying it into a single metric, which you could say is basically utilitarianism on steroids in another sense. So it's not holding social justice and efficiency in tension. It's trying to solve that issue by coming up with like a higher level of metric. So yes, of course, efficiency, they'll count equity now, but you could have a situation where efficiency is just good enough that you could actually forego equity gain to go for that kind of more efficient thing. You don't know that because they're just using a single metric. So again, I use distributional analysis all the time, but I'm also grappling with that issue because this is precisely the arguments that the Germans and other philosophers are coming up with against the whole system. So if you have any insights, please help us out.
Well, I came down to the view I like distributional cost effectiveness analysis because I like it principally because it forces the equity discussion into the discussion. And too often we just ignore the distribution.
Ariel, do you want to come in?
Right, thank you. Thank you so much for your work in moving into this space where not many people have in combining theology and healthcare and economics. And so just wanted to say I appreciate your thought in this. One comment I wanted to make, I just came from a lecture where oh, sorry, my background. I'm a medical doctor from the States, and I'm just finished my PhD at Oxford on uncertainty in medicine. But I just came from another lecture on healthcare where the speaker mentioned that 33% of the healthcare budget goes to bureaucracy. And I wonder if the sites of the conversation on patient treatments and resources and who gets what can actually miss some of the bigger picture of how much resources are wasted in bureaucracy. I know as a physician myself, it's an incredible waste of resources, often chasing quality measures over actual practicalities of patient care and having to bend over backwards, send people in crazy places because of different top-down bureaucratic rules that actually can get in the way of the bottom-up provision of care. So I wanted to hear your thoughts on this.
It's a really good thought stimulus. Now, a lot of my life I've been a bureaucrat. So I'm not going to say bureaucrats are completely useless and should be thrown into the dumpster. Some of us think that good management, improves the functioning of the health system. And that is, if we can, good management might facilitate good outcomes. For example, investing in the measurement of outcomes so that a doctor knows whether they're at the top of the pile in terms of quality outcomes or the bottom is probably a good thing. I remember when I was in Alberta, we just introduced measurement of providing feedback to the orthopaedic surgeons about, I think, their revision rates. And I saw this guy who was an orthopaedic surgeon in Edmonton. And I said, you've got your results. How did you go? And he said, I'm in the middle of the pack. And I said, that's great. That's great. And he said, I've never seen myself as an average surgeon. He didn't know where he performed. He didn't know where he could improve. He didn't know anything about his relative quality of care. And all of that, of course, can be derided as bureaucracy. That's not to say that every minute of every bureaucrat's time is actually sensibly invested. And coming from the United States, you would well know that one of the distinguishing features of the United States is its massive overinvestment in administrivia. It is one of the distinguishing factors between the costs of care in the US and in other countries is this overwhelming administrative costs. And you won't get me to say that every cent of that is worthwhile, but all I would say is some management is good for the system and some might be not. So it's the same cost effectiveness issue for management as it is for anything else.
David in the chat had a comment about whether you discussed the point that Luke himself was a physician.
So I was trained in my early theology study to be very careful about assuming that, inverted commas, Luke was, inverted commas, an individual man who was a physician. Obviously, the Luke is a very different synoptic from some of the others, partly, I think, because of that, the location and the emphasis. But I didn't want to make assumptions about that, so I didn't actually turn my mind to that. Good point, though.
So perhaps while we're on the topic of the Good Samaritan parable, and I think you mentioned at the start that you see it as kind of a universal story. Do you want to maybe talk about the reception of putting that parable kind of at the forefront of your thinking and whether you found the response to be universal?
Yeah, so I was quoting someone else who made that point, that it is, of all of the Christian stories, it is the most one that resonates in any environment. Interestingly, when I was doing this, I gave a draft to another health economist who is active in Uniting Church in Australia. And he said, well, why did you take a Christian frame? Why, a lot of what you're arguing needn't have been argued, could equally apply as a secular argument. I thought, oh, why am I doing that? Well, I think it was coming back to where I started from, Robin Gill's point that, where do the principles that Beecham and Childress come from? Then they must come from somewhere out of their heads, was it? And so where are you going to have your foundational principles coming from was one point. And so that's why I started there. And as I said again right at the beginning, I'm not basing everything on the Samaritan parable, because these principles of social justice are in any number of places in the Bible. Similarly, the issue of stewardship in a number of places. Similarly, the issue of compassion. So it's not as if I'm hooking everything on the Samaritan parable, but it's a nice way of bringing it together. Interestingly, when I'm doing public theology, or when I do a lot of media in Australia, previously I didn't ever use the word compassion. I've started using that in my discourse, and it's surprisingly well received, because often the public economics, health economics discourse is only about efficiency. Sometimes the discussions are about equity, but almost never do we talk about the third part of this trilogy or trinity, the compassion part. And it is something that resonates a lot, I think, with healthcare providers. And so I think my response is that none of that language, I don't refer to the Samaritan parable when I'm talking about bulk billing rates in Australia, but you can trace a link between those principles, which I think is important. I'm not sure that answered your question, Joseph, but
I think it has. So there's a common core language, and compassion isn't that kind of a natural law. Anyway, so David has his hand up. I think Ariel, I think your hand is legacy hand. Yeah. So David, please.
I thank you very much. Really appreciate the conversation. I just a couple of things that just populated my imagination. Comment them on as you like. I liked what the universality of the story for a couple of reasons. One is this idea of compassion. I think one of the things that makes us human in a unique way is our ability to show compassion. In this case, towards the other. This is someone who's completely different. The Samaritan and this other person. I think, at least as I understand that gospel passage, that's part of the point, is to see the other. So seeing the other and then showing compassion and not measuring it, although there is an economic metric in it, but it's not measuring that as the primary driver of the compassion and seeing the other. It's not an economic decision, although there is an economic contribution to it, obviously, literally and symbolically. But it's just a really fascinating conversation. I really appreciate it. Thank you very much. Comment as you like.
Thank you. I think that what's interesting, thank you again. But what the story starts with compassion. It's right there at the start, moved by compassion. And the other things, in a sense, the stewardship comes right at the end of the 2 denarii. But as you rightly point out, because the person on the side of the road has been stripped naked, we don't have identifiable marks. So we have no idea who this person is. It's the unknown person on the side of the road. And it is about the Samaritan was prepared to look after them, whoever they were. That the issue is our relationships with everybody as people.
Thank you. Natalie?
Thank you, and sorry for being late. 5 o'clock in Australia, so I missed the start. Just as positioning, I'm Deputy Chair of Uniting Care Queensland, which is a faith-based large health and community service provider in Australia. And Stephen, I've known of your work, but hadn't known of the theological underpinnings. So hence my signing up for this. And it feels like it's opening up a whole new world. I just want to first comment on compassion. It's one of the values for Uniting Care Queensland. And of course, we've got 25,000 staff and volunteers. When we have our awards night, compassion is the word that comes through so strongly. Of course, we don't have 25,000 Christians working for us, but Christian, non-Christian, that compassion is the value that I think connects us all. So just seeing how you connect those, I think is really valuable. So thank you. The question I have relates a little bit to Ariel's question, and congratulations on finishing your PhD, Ariel. It's a big thing. And it's to do with the administration and also to do with technology. So, you know, my intro into health is through technology and the ability of technology to I guess in terms of health equity, compassion, you know, there's great opportunity there, particularly in a country like Australia, which is so geographically challenged, I guess. But of course, it's a big investment, high risk. So it mightn't be appropriate for this call, but if it is, I'd just be interested in the place of technology in all this.
And thank you, Natalie. Coming from Queensland, it is an hour earlier than real time in the rest of Australia. I guess there is again a vast literature on the use of technology in healthcare. Technology can be a wonderful enabler, and one of the things that I'm interested in at the moment is access to healthcare and how contemporary technologies can make it easier to bring the service to the person rather than being forced to bring the person to the service through telehealth and other initiatives. There has been, I just literally had a meeting yesterday where in South Australia, 20% of the outpatient attendances are by telehealth. Mostly, unfortunately, by phone rather than video, but there's just this move about enhancing access. On the other hand, you have the stories about the nurse at the side of the bed spending all of their time looking at the technology and not any of their time looking at the patient. And so we can have technology, in a sense, replacing humanity in the caring endeavour. And so, like many things, we've got to actually think about the benefits and the costs and how we live with those, recognising, as I said, the massive advantages that we're achieving from technology in terms of telehealth and access and remote monitoring and all of those advances. As you may well know, in Australia, virtual care is booming in terms of ensuring access, not only in remote areas, but also.
Okay, I don't see any other hands. I'll just chip in while I think about the question. So I just wanted to return. Oh, is that your hand, Ariel?
I do have my
Yes,
hand
okay.
up. If I can steal another question.
Yeah,
I'm sorry, I've got a lot of questions I'd love to ask you. One thing I've got is a question about performance measuring. Sort of the idea of the Heisenberg uncertainty principle. In the very measuring of something, you can change the thing. And I see this happening, especially in performance measures. I know you mentioned the surgeon who was like, oh, I'm in the middle of the pack, I need to get better. But I've also seen, I remember working with an orthopedist who his pay was based on his performance measure based on patient feedback. And so he would only tell his patients what he knew they wanted to hear, because then he would get better feedback and get a higher pay. I'd go in with him, I'd be like, why did you say that? I know you don't think that. You just told me the opposite. And he would tell me, oh, well, it's what the patient wanted to hear. I'll get a better review. Or other clinicians who I'd work with who would refuse to see difficult and complex patients because it would decrease their quality measures and decrease their performance measures. And so they would actually not care for the people who needed the most because of their measures. And so I'm wondering, how do you prevent the performance measures from actually becoming abused and getting in the way of care?
Yeah, there's again a vast literature on perverse incentives and poorly designed performance measures. I think one of my responses is to ensure that you're not rewarding behaviour. You're not designing performance measures that reward behaviour that you don't want to encourage. And we often do that. That is, we design a performance measure which is entirely based on patient feedback, and we want them to ignore the incentive effects of that, of only telling patients what they want to hear, for example. Or so you don't want to design performance or incentives which you want people to ignore, and we do. So part of it, in my view, is attenuating it. That is, you don't have 100% on some metrics. You try and balance it, but you don't want to have too many metrics and so on. I chair the board of an organisation here in Melbourne where we are currently redesigning our funding approach, and we are explicit about our indicators, but there are multiple indicators. So on what we call the reward payment, we have 50% based on actually measuring outcomes and 50% on the improvement you get in the outcomes that you've measured. But the outcomes are things like self-reported mental health status, for example, in our mental health programs. So it is often people think that design of performance indicators is simple. It is not. And you have to make sure that they are consistent don't destroy intrinsic motivation, that they don't create perverse incentives, that they're understandable and so on. And it's, as I said, there's often an assumption that, I can just sit and do it on the back of an envelope, and it's crazy. And also it comes back to this compassionate leadership that I talked about, where one would expect that there was co-design with the people who impacted the staff, to call out these issues of what are good indicators and what are not good indicators, and what they reward and what they don't.
Okay,
Thank you.
wanted to thanks, Ariel. I just want to come to one aspect of your book that really interested me, and because there you talk about the Bible being it's not about small changes but transformations. So you cite, for example, Mary's Magnificat as kind of the great leveling process, transformation towards social justice. So I guess I just have a question on what kind of policy do you think will count as kind of prophetic transformation nowadays? And do you think health economists have the right tools to measure that? So, like, how big a change do you think the Bible calls for?
Well, of course, economists always talk of things at the margin, and by which if you take the derivative where it's an infinitely small change that we're talking about. But I guess I would argue that incremental. I'll slip out of the book into another concept, one of the very good health policy academics, a woman called Carolyn Toohey, has looked at change and said you can think of change, policy change, as the pace of change, that is slow or fast, and you can think of policy change as the scale of change, incremental or large. And often we only think of two cases: small scale incremental change, which everybody derides, and big bang change of large scale, fast pace, the introduction of Medicare in Australia being an example. But she actually points out that there's a 2x2 table, and you can actually have examples of change in all of those. So you can actually think about large scale change, which is implemented incrementally. You've got a vision of where you want to get to, and you do it over time. And that's so in a sense, the theory of change I'm addicted to. So it is transformative over time. When I was involved in a major change report in Australia, we talked about the grit in the oyster. That is, you set in place the right sets of incentives, and that will drive a pool that will create a larger scale change over time, just by the incremental effects of change in policy. So yes, I'm strongly in favour of transformative change, but that doesn't mean it's always big bang change. Eileen had her hand up and just disappeared.
And Elliot put it in comment. I think she's doing it. Oh, so he says, according to Luke, wouldn't pay in itself be a perverse incentive compared to the intrinsic motivation of caring for the patient?
Yeah, so I struggled with this. Was I imposing too much on the Samaritan story in drawing out stewardship from the interaction with the innkeeper, the person often ignored in the Samaritan story? You could argue that this is the very reverse of economically rational behaviour. That is, the Samaritan said, you can have 2 denarii, but I'll pay whatever you'd like or whatever you expend when I come back. So you say, oh, is this unlimited spending? But I would argue that, it's for that reason that some people refer to this not as the Good Samaritan story, but the foolish Samaritan story. But I would argue that there is a trust relationship between the Samaritan and the innkeeper. The innkeeper trusts the Samaritan to come back, and the Samaritan trusts the innkeeper to spend money wisely. So there is a financial transaction here that's embedded in the Samaritan story, even though the Samaritan, when he first picked up the unnamed person by the side of the road, then was motivated by compassion, not by money. But then again, more or less every healthcare professional in the world is paid something, as we all have to be. So I don't think, my view, Eileen, is not that pay itself creates a perverse incentive. It's partly how the payment to the individual is structured. As Ariel pointed out, you can structure it in a stupid way, but you can also structure it in better ways. And I'd argue that blending capitation and fee-for-service, and to some extent pay-for-performance, creates the right sorts of incentives in the family physician environment anyway. But yeah. John.
John, I think you have your actual hand up. You have to unmute yourself. Sorry.
Thank you. Terrific presentation, Stephen. Really enjoyed it. The question that I think the ground that you're breaking was bringing so much more into that triangle of theology, sort of economics, and healthcare funding. And I think that the problem that it left me with is the resolution of all of those new parts was the question about how do you manage the tension. It seemed to me that you, in the end, leave quite a lot to the fact that this tension is a necessary component of the whole experience, and how do you manage it at a personal and at a corporate level. And it seemed to me that the two characters who are sort of ignored in the story, the way you've told it, are the two religious figures who pass by. And the parable is also making a point about that debate, if you like, that's going on about faith and what does God require. And the religious people walk past or run past or turn their eyes. And the person who shows compassion is the Samaritan. So there is a judgment implied in the story against those who don't show compassion. And I wonder what the judgment is for those who don't know how to work with the tension. You know, how do you escape an individualistic sort of response to the tensions that are raised by bringing all these parts into the public sphere? Because the public space is, in a sense, a world that the church has abandoned in social policy terms. And I wonder if you could say a bit about how the churches, perhaps, or religious figures are challenged by this judgment that raises the compassion of the Samaritan, but against the behaviour of the people who ignore the woundedness.
Thank you, John. About 106 questions embedded in all of that.
Yes.
I'll try and cover some of them.
Sure.
I think that one of the issues you raise is about the place of faith-based organisations in a world which is surrounded, in which they are surrounded. And I've turned my mind to that in a recent paper published in the journal Theology, which I call in my little filing system, I call the Theology of Welfare. It is about, in my view, the importance of faith-based organisations proclaiming their traditions and standing firm to their traditions and not just abiding by the terms and conditions of contracts and doing whatever they're told, but they have a prophetic role in our society. And so it is up to faith-based organisations, I think, not only to meet minimum standards that are imposed on them, but to actually say, is this consistent with compassion, stewardship, social justice, and so on? And that can be hard. So that's one answer. Another answer is the world is grey. Nothing is clear cut. If things are clear cut, we wouldn't have these debates. And that's why I talk about the tension between these principles. No one of them, in my view, is preeminent, and we have to live with those tensions if we are in the healthcare system. That is, and we have to acknowledge that we are in this world of uncertainty, this world of nuance, rather than a simplistic world where everything can be crunched through in the incremental cost effectiveness ratio. I do not believe, when I was a school student in my early years of school, the answer was always in the back of the book. That is not what life is like at my age. That is, life is much more reflection and so on. And so the parallel is in any organisation in the healthcare system, we have to recognise that the world, that things are not on the management side, and even on the clinical side. We have to remember that there are trade-offs, that there are competing issues that we need to take into account. And we have to be careful that we don't imagine or pretend that there's an obvious answer and it is pursuit of efficiency, or there's an obvious answer and we have to do whatever. I mean, in Victoria at the moment, there's has been quite a furore about the closure of a primary medical care service run by a community health centre. And the public debate about that has been quite interesting. It was, we're providing perfect care, and if we can't provide perfect care, we should provide no care at all, which is quite an interesting choice. But we're not saying don't provide bad care, but so it's really quite trying to understand that you are always setting priorities. You are always talking about efficiency. Your organisation can't survive if you don't have money. Similarly, you should always be talking about who are we serving. You should always be talking about how we're serving, why we're doing it, and so on. So that's why I use this concept of tension. I don't know whether I've answered your question, John, but it is all of these. There's not a single answer.
John, you're on mute. Did you want to come back to that for that? No, it's okay. All right. I guess if I kind of build on that question, so I mean, we all accept that there is a tension, but is there kind of a distinctly Christian way of solving that tension that is different from a non-Christian way of handling that tension?
Yeah, it comes back to this question of to what extent is the parable universal, and to what extent are the three principles I've elicited from the parable universal. I think there's not a bureaucrat manager in the country who doesn't think stewardship is important. They might have a very narrow view of stewardship, but there's not one who doesn't. Stewardship is important in any country in the world. To what extent do you emphasise social justice and equity? That varies a lot in different countries, as we see. And over time in the same country, this issue of social justice may or may not be high or low in priorities, sometimes relating to political parties, sometimes the minister or the leader or whatever. You have quite different views on that. And compassion may be squeezed out, as I talk about, and the emphasis of austerity and squeezing out time for compassion. So I think, as I said, a Christian ethic involves thinking about all three of those. Would a Muslim ethic or a Sikh ethic or have exactly the same three tensions? To some extent, that may be true. I'm not enormously familiar with any of those other faiths, but certainly the Muslim faith has elements of all those three in its writings. So they may be universal faith-based principles rather than Christian principles. But I'm not sure enough on my ground to give a clear answer on that one.
But you wouldn't think, for example, compassion, out of the three, compassion might be the one which is most at risk, because I think most politicians do talk about justice, they do talk about efficiency. But even though you did say compassion is part of the public language, it's probably the weakest of the three. So perhaps the Christian response should be, it is a vital part of the Trinity. And It has to be.
And it's the one, I agree that it's one most at risk and the one you hear least about in the public discourse.
Right. So on that note, unless if there are any other comments or hands up, oh no, Ariel, I deliberately scroll through just to check. But you had another hand, yeah. So perhaps final comment tonight.
I'm curious, how do you create healthcare systems that can really reimburse and value relationships? Especially like the sense that you had in the last slide of this being not doing. That's hard to reimburse for and write into an economic system. And that's actually so much of the heart of sitting with that unfixable suffering. How do you create a system that can economically account for that? Or any ideas you have? Anything's helpful.
Yeah, really good question, Ariel. Maybe I have to answer, I don't know. I think it's partly coming back to this point earlier, you don't want to put incentives on in front of people that you want them to ignore, but you need to actually ensure that the incentives that you are putting in front of people and the designs you're creating, the design of the system is one that does the right thing. I mean, in Australia, we've gone through waves of neoliberalism and non-neoliberalism and so are we creating healthcare markets which are about doing things and measuring widgets in a way which you would find appalling? Or are we creating a service network where there is collaboration and we build improvement based on learning from each other, and not everything we do is intellectual property and so on? So in my work, I try and avoid the discussion of use of the language of a healthcare market and try and talk about a healthcare service system, so that I'm de-emphasizing this quantification and of everything and trying to emphasize that we are together, we are trying to improve, and it is about being with, we can't be a person without being dependent on another person, as Desmond Tutu said. But thank you for challenging me on that one.
So on that note, I'll bring it this particular communion relationship of ideas to an end. So thanks again for Stephen for joining, and Natalie as well for joining so early from Australia. And again, I think we are breaking new grounds. I think here at Las Casas has been such a good institution to host us in this step forward. So okay, so any final words from you, Stephen, to sum up?
Yeah, just thank everybody for the great questions that you asked and the stimulus that you've provided me. So it's been really enjoyable, even though it was 6 o'clock my time, not the 5 o'clock that Natalie suffered. But thank you very much. It's been really good for me.